Good morning, everybody, to this morning's session of NTW 22 on updates in anticoagulation for cancer-associated thrombosis, the what, when, and for whom. Nathan Hutchinson-Jones is an anticoagulation specialist pharmacist based at Royal United Hospital, Bath. He started work at Bath in May 2017, and before then was involved in the Don't Wait to Anticoagulate project, which looked at optimizing anticoagulation therapy for patients with non-valvular AF. It was this project which evoked Nathan's interest in anticoagulation. In his role in Bath, he participates in a weekly thrombosis clinic, has set up a new cancer-associated thrombosis service, which I learned today was inspired by Professor Simon Noble, and works as part of a multidisciplinary team supporting primary and secondary care clinicians, helping to optimise anticoagulation services. So without further delay, let me pass over to Nathan. Thank you.
Yeah, thanks, Joe. And yeah, absolutely. It's great to be sort of involved with this talk, Simon. And I was just telling everyone before you joined that one of the reasons that we set up the service here was because of the work that you've done in South Wales. So great to be involved with this and to see what you have to say. I've got a bit of a bio to say about you, Simon, so I'll start off with that. It's not very long, but just to introduce everyone, so Professor Simon Noble is a supportive and palliative medicine consultant in Cardiff University and honorary consultant at the Royal Gwent Hospital in Newport, where I previously worked as well. His main research interests are the management of VT in advanced cancer, the anti-cancer effects of heparins, and the quality of life associated with VTE. Simon set up the South East Wales Cancer-Associated Thrombosis Service, which sees up to 500 new cases per year. He's involved in many research studies and was chief investigator on the international Pelican study, which explored the impact of cancer-associated thrombosis on patients in different countries and healthcare settings. On top of considerable work, Simon's also medical director of Thrombosis UK and enjoys hill walking, travel, and hip hop, which I think is quite an interesting thing to know about you, Simon. So, and with further ado, and any questions, as Joe said, please pop them in the chat. I'll go through them all, and at the end, we can have a bit of a discussion. So I'll hand over to you, Simon.
Many thanks, Nathan. And yeah, delighted to see that your CAT service is going so well. Honoured that the work that we've done in South East Wales has influenced that, because it means at least one person has listened to what I've had to say, which you know, sometimes it's hard to convince myself that anything I'm doing is worthwhile. So you know, that's my Dear Diary moment for tonight. I'm going to talk today about cancer-associated thrombosis. For those who've not really attended many CAT talks before, I'll just cover a bit about the pathophysiology. And also, I will just try and give us a sensible, but what I'd like to think is a healthily cynical overview of where we should be at the moment. So I will just share my screen, and I am making the assumption there that you can see my talk. If Joe or Nathan could just say yes, that you can see it, I'll be grateful.
Yes.
Yeah.
Perfect. Okay. So these are my disclosures. You know, when you get to do a few talks and people like them, you get asked by different companies. It's an interesting experience. Sometimes it's quite frustrating when their compliance gremlins come in and want to make it 100% squeaky clean, which when I talk about palliative care, where there is no evidence base, and I put all these slides up of which there's no references, they get a bit stressed, but that's entertaining as well. I've also sat on, or am sitting on, 3 different guideline groups, of which they were certainly 3 different types of experience and 3 different types of methodology. And I'm going to talk a bit about the guidelines later. So just to introduce this topic, I get letters from colleagues from time to time, and this one I got just at the end of January this year. Dear Simon, just seen this article on the British Society for Haematology website. Do we need to rethink our current management of CAT patients? Refers to your clinic. Best wishes, Dr. Smugly. And this is the Dr. Smugly who previously wanted to convert all his upper GI esophageal cancer patients to DOACs because he thought it would improve their quality of life. And I had to explain that the data at the time from the Hokusai cancer study had shown a 13.1% major hemorrhage rate in patients with GI cancers. So maybe one needs to read beyond just the abstract, or in this case, the headlines. So I had a look, and this was the link that Dr. Smugly had sent me. Direct oral anticoagulants should be the standard of care for cancer patients with thrombosis. And I had to go straight in to read this because I couldn't think of any study that was about to come out that, could alter this. I wasn't aware that there was another DOAC study coming out, or was there new data? I mean, to talk about how important this was, it actually interrupted me doing my web search for tractors, which, we all know is an acceptable thing to do on professional work computers. So what was the issue here? First of all, this is a big challenge to say DOACs are the standard of care. For so long, low molecular weight heparin has been the standard of care. And, you won't be unfamiliar with this slide, which showed that in 2003, Aggie Lee and colleagues ran a randomized control trial comparing dalteparin with warfarin in patients with cancer-associated thrombosis. And there was a 50% reduction in recurrent VTE. And that, plus other studies comparing low molecular weight heparins with coumarins or warfarins, quite conclusively showed that low molecular weight heparin significantly reduced the rate of recurrent VTE. Low molecular weight heparin also had some other advantages. The number of drug-drug interactions were very few and far between. Patients who had nausea or absorption difficulties, this could be given to them because it had, it was given parenterally. We didn't need to do levels because this was given according to body weight. And, most of the agents that were available were quite safe in patients with creatinine clearance 30 and below, maybe even as low as 20 to 25 mils per minute. So then the DOACs came along, and I'll give you a brief overview of them, but I'm just going to focus on the CARAVAGGIO study because this is the most recent one. And the studies have tended to show the same thing. And so what we're looking at here is a study where patients with cancer were randomized to either have apixaban in its usual licensed dose of 10 milligrams BD for a week, then followed by 5 milligrams BD for 6 months, or dalteparin 200 units per kilogram for the first month, and then the dose dropped down as per the clot protocol. And they would look then at major bleeding, clinically relevant non-major bleeding, and VTE recurrence. And this showed that actually the rate of recurrent VTE in apixaban was lower than dalteparin. But, and we'll see in a minute, that was at the expense of bleeding. Now, here's something interesting, though. If we have a look, these Kaplan-Meier curves only start separating at day 30. So up until then, they seem to be getting the same results. And the reason I think this is interesting is that it is around day 30, which is 1 month, that we drop the dalteparin dose down from 200 international units subcut once a day to 150. So we drop the dose by a quarter. And that's when we start seeing the advantage with apixaban. Now, what makes this even more interesting is that the CATCH study, which was tinzaparin versus warfarin, they didn't reduce the dose. And there wasn't an increased rate of bleeding in the tinzaparin arm. So I know some colleagues who actually won't drop their dalteparin down after a month and will keep it at that level because they want to anticoagulate the patients as much as possible, and there's no associated increased bleeding risk. So I do wonder that if this study had been done on dalteparin, which was maintained at 200 units per kilogram, whether we would still be seeing that difference. What it also does, though, is it does give us a bit of free time to start a patient on heparin and then decide in the cold light of day whether we can convert them to an oral agent, because certain things need to be considered here. Just so you can see there in CARAVAGGIO, the bleeding rates. Major bleeding, no difference. And also no difference in GI major bleeding. Now, how much of that is due to the molecule of apixaban being more favorable than we saw with rivaroxaban and edoxaban in the SELECT-D and the and the Hokusai cancer studies? We don't know, or maybe it was that there just were fewer GI cancer patients enrolled into the study. But there was a higher rate of clinically relevant non-major bleeding. And the sort of things we're talking about there are hematuria, epistaxis. And so, there is an increased rate of bleeding. And, these studies will say caution needs to be exercised in patients who are at risk of bleeding. So currently our practice is that patients will get commenced on a low molecular weight heparin and referred to the CAT clinic. And we will then make the decision at that 1 month point, and we'll have a multidisciplinary team meeting, and we'll discuss which patients can go on DOACs and which patients can or should stay on a low molecular weight heparin, because it's not as straightforward as all DOACs can be used in all patients. Let's just have a quick overview here of the pathophysiology of cancer, and then we'll go back to the DOAC data. So we know that the cancer itself can increase the risk of thrombosis, usually by induction of inflammatory cytokines, but also by the release of procoagulant molecules like tissue factor. And we know that different cancers have different thrombogenicities. We also have platelets can be activated, and then there are extrinsic factors, chemotherapy, and we're also seeing that the targeted therapies, the immunotherapies, are also increasing the risk. So the developments we have in oncological treatments continue to increase the risk of clots. So as we have patients living longer with metastatic disease, getting older, and continuing to have systemic anti-cancer therapies throughout their life with metastatic disease, we are seeing the rate of VTE going up. So this is not going to go away. And these people are living with clots for longer. So we are not now just looking at patients having a 6-month treatment. The guidelines would recommend that patients with ongoing active cancer or receiving systemic treatments should continue indefinitely. As I've said to you before, different cancers have different thrombogenicities. This is just one example here, which shows that things like lung, GI, brain, myeloma are highly thrombotic. But in any cancers, the presence of metastases increases the risk considerably. And in my clinical practice, the commonest cancers I see with clots will be breast cancer and colorectal cancers. And that's because they are so common, because these are the patients who are treated with surgery and chemotherapy, and also will receive systemic anti-cancer therapies throughout their lives, even if they develop metastases. Now, we also know that the majority of patients we see are diagnosed with their cancer-associated thrombosis in the first 3 months. And that will be because that's when they will embark on their systemic anti-cancer therapies, which can lead to them getting clots. And it also may be that that's when we're doing their staging scans and the incidental PEs are picked up. Now, we don't know how much this picture, because this is from over 15 years ago, whether we're actually seeing higher rates now at the subsequent months. But I think the message is a high vigilance in the first few months of someone's diagnosis of cancer. And the other thing that's important to recognize is that the risk of thrombosis is not constant in a cancer patient. Now, first of all, the risk of thrombosis is not like other people who have, say, hospital-acquired thrombosis from one episode of illness, where the risk goes up very high for a while and then it wanes after, will have waned completely after 90 days. Patients with cancer, as long as the cancer is there, will have a baseline thrombotic risk. And then things like chemotherapy, hospitalization for an acute illness will lead to peaks in those risks. And my clinical practice, at least 60% of the people who come through my door will have had their cancer-associated thrombosis precipitated by chemotherapy or systemic anti-cancer therapies. Patients who are in remission or who have responded strongly to their treatments, the risk may drop down, but then if the cancer comes back, the risk will come back. And certainly as disease progresses, we are seeing an increase in VTE. A prospective observational study we conducted a few years ago in the hospice showed that 30% of patients had evidence of femoral deep vein thrombosis, although they didn't have symptoms from it. And just to demonstrate to you that CAT is a growth industry, it is not something that is going away. In fact, it is on the rise. You can see here that the incidence of VTE, cumulative incidence of VTE is on the up. And on this other side, we can see the impact of different systemic anti-cancer agents. And we see here, and I think the important thing is protein kinase inhibitors, anti-angiogenics, immunotherapy, all increase the risk of cancer-associated thrombosis. And because these are often being used long-term, some people may be on these for years, the risk of VTE will be ongoing. So what do we know about the DOACs? Well, I like to put this is Prince, who was then called the artist formerly known as Prince. It was the same guy, but he changed his name. And that's pretty much what happened with the direct-acting oral anticoagulants. When they first came out, they were NOACs, standing for new oral anticoagulants. Then they were no longer new, but we liked the end, so we called them novel oral anticoagulants. And then there was a parting of the ways between hematologists and cardiologists. They continued the end, so they were called non-vitamin K oral antagonists, and the hematologists decided to call them direct-acting oral anticoagulants. So we refer to them as DOACs. 4 different sorts. You'll forgive me if I don't spend any time talking on dabigatran. That is because we don't have data in the cancer population on these. But rivaroxaban, edoxaban, and apixaban have all been evaluated. I think the key things to note here is different levels of renal excretion of these drugs, and also looking here at metabolism in the liver with CYP3A4, whether it's a major thing, or with edoxaban, CYP3A4 is minor metabolism there. And then P-glycoprotein, which is a transfer protein, because these things are involved in the metabolism of the DOAC. So if we look at meta-analyses of the 3 main anti-cancer studies, they pretty much, it concludes the same thing. And it shows us that they are as good as, if not better than, low molecular weight heparin in preventing recurrent VTE. But that may be at the risk of major bleeding. And depending on which studies you look at, the areas of major bleeding, and in particular clinically relevant non-major bleeding, tends to be focused on GI cancers where the intraluminal tumor is still present, and also urothelial cancers. So back to this headline. What was it that this, what was the new data that came out? Because I was getting a bit stressed. I thought, am I not keeping up to date? And actually it was this. Direct oral anticoagulants compared with dalteparin for the treatment of cancer-associated thrombosis, a living, interactive, systematic review and network meta-analysis. So it's a meta-analysis. I'll be honest with you, we don't need more meta-analyses. We need more data. Since 2015, so since the DOACs have come into play, there have been over 40 CAT guidelines, consensus documents. So those are basically guidelines which don't have a systematic review and meta-analysis, are usually a group of experts sat around a table convened by pharma and then agree on a few principles which a medical writer will then write up for them. And there have also been some commentaries on guidelines in which people have looked at them and graded which ones are good and which ones are crap and which ones have used the right methodology, etc. So when I saw this, I kind of breathed a sigh of relief because I thought, phew, there's no new data. It's just another systematic review that has managed to actually capture a very good headline. But Dr. Smugly is not the only person out there who would read this and think, I can now go ahead and give DOACs to every patient that crosses my threshold. And I think DOACs are great, no question. DOACs are great, but only when used safely and with the right patients. And this is where we come to the clinical guidelines as well. Clinical guidelines are great so long as there is evidence to guide them. And there's two things that you need to consider when reading a guideline, and they don't always give this data. So number one, if there is no data on something, some of these guidelines just come up with unhelpful things like we can neither recommend nor advise against such and such, which when you're facing a patient who's sick with a DVT or a PE and you're looking for the evidence, that sort of advice is unhelpful. The other thing is you need to understand how much the data is representative of your particular patient. And so to do that, you need to understand which patients were excluded from these studies and actually how many of the population would have got into these studies if offered the opportunity. So I really feel that DOACs are, as you know, they're only safe in trained hands. Just to understand, first of all, GI-related bleeding. If you've got an upper GI tumour, and also you could even argue a lower GI tumour, if the mucosa is still, if the tumour is still present in the lumen, you have a higher risk of GI-related bleeding, particularly in esophageal and stomach. We know that, say, apixaban is absorbed throughout the intestine, and so therefore it is incompletely absorbed as you go down, and there will be topical anticoagulant effects. So if you've got a highly vascular tumour or a weeping tumour, it is likely to lead to bleeding. Things like dabigatran does have a direct caustic effect, and that's why we were seeing these GI signals so early on in those studies. And also, there's inhibition of mucosal healing by these drugs. So GI tumours, and also because we're seeing these being excreted, parts of it being excreted unmetabolized via the urine, patients who have bladder tumours, urothelial tumours, we are seeing hematuria in those. Now, people sometimes go, yeah, but it wasn't, statistically significant. It's clinically significant, believe me. Actually, patients with atrial fibrillation on DOACs, hematuria is a very good early warning sign of a bladder tumour, as we're learning in our practice. The other thing is that these people are continuing on anti-cancer therapies. And every ASCO, there will be another few drugs ending in IB, which will have interactions with CYP3A4 and P-glycoprotein. And one of the things that we do very carefully in our CAT-MDT is say, what systemic anti-cancer therapies is this patient on? Are they on things that are going to interact with the DOAC so that the DOAC level is either put up, increasing the risk of bleeding, or the DOAC level is dropped, which will decrease the anticoagulation effect of the drug. Dexamethasone, patients on high-dose Dex, I've seen people whose anticoagulation has been beautifully controlled, and then they got put on Dex and they've had another clot. So you've got to be very careful about this. And I tend to use 2 different drugs databases to check whether there are interactions there. So clinical guidelines, and I'm going to show this in different pictures, are very good for a set group of patients who all look pretty much the same. But when you've got no data, you've got no guideline. And so I look at my palliative care patients, the guidelines are very unhelpful for them because none of my patients would have got into those studies. And so let's just have a look in the real world and see what proportion of patients out there would have got into the studies. So we look at Hoxside cancer, really good study, just over 1,000 patients randomized. Now, I've read that paper and I've read the appendices cover to cover several times. I know I'm sad, but I do this reading so you don't have to. And can I find anywhere which tells me the number of patients that were screened and that didn't get into the study? Or here, I don't even know the number of patients that were approached but declined. So that isn't very helpful. I've no idea what proportion of the population, because we had sites all over the world recruiting, but I don't know how many patients in the real world could not get into the study or would not go into the study. CARAVAGGIO, 1,000 patients, just under 1,200 patients. Once again, don't know how many patients could not get into the study because they didn't meet the criteria or they declined. Adam VTE, likewise, couldn't find it. The only one I could find is Select D, which, thank you, Annie Young. They assessed 2,060 patients, of which 1,105 did not meet the inclusion criteria. And then a further 500 and a bit did not participate. So let's just kind of back of a fag packet say the one study we've got here that gives us an idea is telling us that 50% of the population would not meet the inclusion criteria and couldn't go into the study. So what are the exclusion criteria, shall we see? What are the things that would stop someone from going in? Life expectancy less than 3 months. Well, that's pretty much all my patients that I see in palliative care out. Performance status worse than 2. Once again, that's pretty much my patients out. Poor renal function. And actually, they reckon about 50% of the elderly have a creatinine clearance less than 30 mils per minute. And then poor hepatic function as well. So that takes a lot of patients, especially the elderly, out of this. The other thing that I find interesting is we are very happy to compare the low molecular weight heparin studies at face value and just compare them with the DOAC studies. But when you look at these different issues in the patients, we look at what proportion had a 6-month mortality. In the clot study, 40% of patients were dead at 6 months. This is a sicker patient population. Just under 70% had metastatic disease. Now, with the exception of CARAVAGGIO, once again, we're seeing, Select D, Hoxside cancer. The patients were, less patients had metastases, which is a major thrombotic indicator. Performance status of 2 or up to performance status 2. Sorry, how many had performance status 2 rather than 1 or 0? A third in clot, whilst 20-something% for the others, although Adam VTE had some very healthy people in there. And then the proportion that was having systemic therapies, once again, we see that clot had the largest number. So basically, you're seeing patients, by and large, in clot and the low molecular weight heparin studies, were sicker with more advanced disease, and the patients that are being selected in the DOAC studies had a better prognosis. So you're getting better outcomes. We are getting fewer complications because these people are in better nick. The other thing is, if you look at various real-world studies and looking at patients with advanced cancer with CAT, the data that's being reported, the patient's got a median age of about 77. Whilst when we look at the studies in the DOACs, the median age is between 64 and 67 years old. So we're talking about a younger population. The guidelines are based on a younger population that is healthier than the ones we're seeing. So just blindly using DOACs on all of our patients because the forest plots are looking better isn't taking into account the individuality of our patients and the fact that these data only apply to 50% of the people that we see in our day-to-day lives. So there's the Stepford wives, all look the same, all shop the same, all speak the same. So absolutely fine, they would all get DOACs. But, you know, anyone who's slightly different won't fit in, may not benefit from a DOAC. So you need to individualize this. Now, in practice, all these guidelines saying the same thing, perhaps different little nuances. Well, what difference does it make, as Morrissey once sang? Well, here's a couple of the most recent guidelines. The BSH guideline isn't here because it's not yet been approved and published, but the ASH guideline, which was developed using basically grade on steroids methodology, and then the ASCO clinical guideline, have both been released. And I took a few patients that we saw in clinic and had to make decisions on, and just looked to see how much help would these guidelines be to the uninitiated, that if you said, I have a clinical problem, let me have a look at this 50-page ASH guideline and see whether it helps me answer my patient problems, or will the ASCO one help? Let's have a look. So these are patients who we saw at 1 month, discussed and thought, can we introduce a DOAC or not? Or what are we doing for their management? So last week's clinic, 65-year-old female. So these are all real patients. These are just, and there's nothing special about these. These are pretty much day-to-day stuff for us. I think 50 to 60% of the patients that we see coming through our doors are not manageable by the data in the current guidelines. 65-year-old female with metastatic breast cancer. She had segmental PEs which were symptomatic and provoked by lapatinib, which is ongoing. She's had 2 episodes of epistaxis whilst on anticoagulation, which have required hospital admission. So the issues here for me are, one of them is they're on lapatinib. So do we choose an agent? And is there an agent here that we can use which doesn't interact with lapatinib? So ASCO does give you an overview of drug-drug interactions. ASH doesn't. ASH just says avoid drugs which interact with CYP3A4 or P-glycoprotein. So you're then going to have to go off and look those up online. And then how do you manage someone's anticoagulation after they've had major bleeding? And neither of these guidelines will outline that. Another one, this patient, or this sort of patient, always keeps me awake at night. 70-year-old male with glioblastoma multiforme, steroid-induced diabetes, so he's on steroids as well, multiple pulmonary emboli with right heart strain. So we know that this is someone that we really do want to be anticoagulating as much as possible. But are there conditions that need thinking about with patients with glios? And the answer is yes. If you look at the work Jeff Zwicker has done, and he's done meta-analyses on patients with brain metastases and primary brain tumors, glioblastomas, what he identified was there's no increased bleeding rate in anticoagulating patients with brain mets compared to those who are not anticoagulated. So if a patient has brain metastases, do not be afraid to anticoagulate them so long as you do so safely. Even the more vascular brain mets like melanoma, thyroid, testicular, there doesn't seem to be a higher rate of bleeding. But glios, there is a high rate of bleeding, and these are highly thrombotic cancers. Appears to be related to the release of something called podoplanin. But someone who's got a glioblastoma, depending on which data you read, the rates of bleeding on anticoagulation have been reported to be as high as 25% in one series. Other series, it was lower. So anticoagulation for patients with brain primaries and whether we should do anything different. ASCO do cover it, ASH do not cover it. And then there's this other question as well, that if you have a patient with a large clot burden, should we treat them differently? And also, should we treat someone with a high bleeding risk differently? And the guidelines don't help us on that. And yet this is something that we're facing all the time. And here's a final one. See this all the time. 78-year-old male, myeloma has progressed through treatment. They've had a large volume PE provoked by lenalidomide and dexamethasone when they were having treatment. And they've been anticoagulated long-term, but their renal function is now deteriorating. There's evidence of marrow failure. The platelet count is dropping. And if you have a look at the guidelines, is there anything there that would help us know what's the best thing to do with this patient? And there isn't. In fact, we don't have, I don't know any guideline which actually tells us when to stop anticoagulants other than if the patient is cancer-free and has had 6 months anticoagulation. Otherwise, we use this kind of wishy-washy caveat of you should make an individualized decision with each patient based on their kind of preferences and hopes for the future and bleeding risk and yada, 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 yada. Doesn't really give us much of a pragmatic guidance. So I want to take you back to this concept, evidence-based medicine. And when David Sackett and colleagues wrote this seminal BMJ editorial, they were very clear that evidence-based medicine was a composite of three things. The relevant scientific evidence, and I do like the fact they say relevant scientific evidence here. So I would suggest that does not mean extrapolating data from patients with traumatic brain injury and applying it to a cancer guideline. Clinical judgment, because we are clinicians, we have looked after patients, we have seen a lot of things, and experience does count. And also patients' values and preferences. And all three of those contribute equally. But I would suggest that what has happened is we have got to a point now with some guidelines where the relevant scientific evidence bit has taken over everything else. There will be a nod to patients' values and preferences, which is a euphemism for we will have a patient partner sit on the panel who doesn't actually say anything and doesn't feel they can say anything. And clinical judgment will go out the window to the point that anyone who's ever done a lecture for pharma is considered so tainted that their vote doesn't count. And they will have systematic reviewers with no clinical experience drawing the data and not understanding what data they are drawing. Crumbs, I've got jaded, haven't I? So I just want you to remember that doctors, nurses, pharmacists, allied health professionals, physiotherapists, occupational therapists, secondary and tertiary care. Patient care is as much an art as it is a science. And Truso, who we normally put in at the beginning of a talk because he discovered the association between cancer and clots, even he recognized this. And he once said, every science touches art at some points. Every art has its scientific side. The worst man of science is he who is never an artist, and the worst artist is he who is never a man of science. Now, I would like to say that he, she, they, whichever you would like to put in there. So finally, and this is what I'm finding in my clinical practice, we don't get a choice in which patients we get to treat. We're not allowed to just treat patients with a median age of 64, of a performance status of 2 with no bleeding complications on drugs which don't interact with DOACs. That'd be lovely. But you can do as many meta-analyses as you like, and believe me, we have, and believe me, we'll continue to do it. But we're still not, they're not going to give us the answers to those patients excluded in clinical trials. The data we are seeing is the best case scenario. These are highly regulated, carefully monitored studies which have been designed to minimize harm. We've removed those with poor prognosis. We've removed those of poor performance status, those at high risk of bleeding, and some of those who would be at high risk of rethrombosis. So we're seeing the best outcomes here, and that doesn't cover all our patients. So once again, another person to say the same thing. Medicine is not only a science, it's also an art. It does not consist of compounding pills and plasters. It deals with the very processes of life which must be understood before they may be guided. So thank you for your time. I do hope we certainly have time to answer questions. Thank you.
Yeah, thanks so much, Darren. That was so interesting. And I think I really like that you highlighted the gaps that there still are really in the evidence base, isn't it? And as someone who runs a CAT clinic as well, you do get these patients where there isn't any evidence really on how best to manage them, and you really do have to sort of individualize it. And I don't know about you, Simon, I think a lot of the time as well, I'm sort of guided sometimes perhaps on what I've done previously and what I've seen in practice as well sometimes, particularly thinking about things like DOAC use in patients with pancreatic cancer. That's one example I can think of in the back of my head. I always feel a little bit uncomfortable with using it because I find they tend to clot quite a lot, and I've just not got good experience. So you do get influenced by that. I wonder if anyone's got any questions. There's nothing on the chat at the moment, but if there's not, I have plenty of questions. I
was going to just make a comment to what you've said there, Nathan. I think one of the things that is to the advantage of doctors is that we are able to go off-piste and make a clinical judgment and use medicines in an unlicensed way. Now, I think for nurse colleagues and pharmacy colleagues, the regulations are such that you have to keep far more within the license certainly if you're a prescribing pharmacist or nurse. And therefore, there will be a lot of patients that standard pathways will not cover. Now, talking about pancreatic, I think there's a couple of issues there. Number one, it is a highly thrombotic cancer. Number two, it's upper GI, so is there a bleeding issue? Well, actually, because we're not looking at an intraluminal tumor, certainly the data from the studies would suggest pancreatic isn't at a higher risk. So I don't have a problem with the DOAC from that perspective. But if I'm looking at a patient who's got floaty, pale stools, and their, some of their endocrine functions are off, they're not secreting bicarbonate, they're not neutralizing the acid as it goes through the small bowel, or you've got an inflamed small bowel, you're not certain actually how much of this is being absorbed. And so these are the patients which we'll discuss in the MDT. Now, we're fortunate We have a laboratory where we're able to do levels. And although we find them hard to interpret, what we can at least see is the drug being absorbed? Are we getting super high levels or super low levels? And so, that is where the, as well as having a dedicated CAT service is important, but we feel that there's 3 of us and we will come to a consensus agreement so that then if this practice was called into question, it isn't just one person's judgment call.
Oh, yeah, sorry, Simon. I was just asking you whether you don't have levels patients who are on the drug.
So all I heard there was whether I do DOAC levels.
For interactions.
Oh, I see, for interactions. This has been done. My default is, if in doubt, use low molecular weight heparin. Now, if we've got a strong inhibitor of CYP3A4 and P-glycoprotein, I'm not touching it. I'm just saying, no, we're not doing it. There is data now which has shown that if you give a DOAC with a strong CYP3A4 and moderate P-glycoprotein inhibitor, the bleeding rate goes up by about 1/3. So I wouldn't even question that one. But it's when you've got a kind of a mild, or we're just not quite sure what's happening with it, we may do a level. Now, the other thing that we do, and this is what's done in other countries, certainly this is what my Canadian colleagues do, is they'll use edoxaban for those patients because you're not getting such an interaction or dependence on CYP3A4.
Thanks, Simon. I've just very quickly changed my headphones.
That's better. Oh, you sound wonderful now.
Simon, I'm having a bad day. Anyway,
yeah, don't worry, mate.
Anyway, moving on. But there's a question in the chat just before we finish. Somebody has asked about line-associated thrombosis, and they've asked a question. I mean, obviously, this is a group of patients who were excluded from the trials, isn't it? So we don't have data about using the DOACs. I imagine people are using them for PICC line-associated thrombosis in some settings. The question specifically, though, is about how long you would anticoagulate those patients. And I suppose, would you anticoagulate them for 6 months, like another CAT patient, or do you use a shorter course, or how do you manage them?
So the guidelines currently with a line thrombosis would be to anticoagulate for 3 months. Now, I would do that up until, on the caveat that person is no longer got the line in and isn't receiving systemic anti-cancer therapies. If you are continuing on anti-cancer therapies through that line, I will continue that anticoagulation. Now, with respect to whether to use DOACs in lines, as a purist, I would say no, we don't have that data. So we use low molecular weight heparin for these patients, certainly for the first 3 months, because we've got evidence that works. And most kind of guidance is that if you've got RCT data in favor of one thing and not the other, you should go with the agent where the RCT data is. But once again, medicine is an art as much as a science. And so intuitively, why wouldn't these drugs work as well? But whether one could defend it medical legally when there are alternatives available. So that's what I would always aim for. But I will also make an individualized decision. So a patient who's, now kind of coming into their 4th month, they've got very little body fat and their belly is just lots of lumps and bruises, I would feel that the risks associated with not treating that clot properly, I think have gone. We've done the optimal resorption of that clot. And so long as there weren't significant interactions and there weren't bleeding risks, yep, sure, go for it. We just don't know. But at the moment, I would do that. Katie's asked, how do you know it's a PICC line thrombosis and not a CAT? Well, I don't. But what I know is that there is an accumulation of factors. The way I look upon it is, here's the bar you've got to get over, and then you have risk factors. So you've got your cancer, you've got your line, you've got your chemotherapy. So I suspect the things that tipped you over here will be the PICC line and the chemo going in. And so I would say we know that 3 months is enough time for your clot to resorb, to stabilize and resorb. The rest of the time we're giving is basically secondary prevention. Now, if you're no longer got the line in and you're no longer having the chemotherapy, that secondary prevention is less necessary. So 3 months would be okay. Whilst if you're still receiving systemic anti-cancer therapies, I think you need the secondary prevention.
Do you do the same, Simon, if someone has had the line removed, but they've had like a port put in? Just out of interest.
I don't know. I think you could argue it. See, the thing is, we don't know. The person's still got cancer. They're having a vesicant, they're having a regular therapy. So they've had a clot. You could argue it. You can argue it both ways.
And I think, again, it's just highlighting, isn't it, the gaps in the knowledge that we have. And I think you really do have to individualize it. The other thing, Simon, is before we finish, someone has just asked, you mentioned about some databases where you might look up interactions. Are there specific ones that you might look at?
So the one that I find very helpful is there is actually a cancer drugs database, which I think is run through Liverpool University. There's one drugs.com, which isn't as thorough as I would like. So I look at drugs.com and I look at cancer drugs with Liverpool. Now, my colleague Raz has another one. I think the pharmacists have access to even more sexy databases. And I think you just need to get, if you've got a couple of databases which say, this seems to be safe, you've covered yourself here. That's the thing. I don't want to knowingly be putting a patient at danger. And if 2 readily accessible databases are telling me there's no interactions, I'm comfortable.
That's great. Thank you, Simon. So I think we've probably run out of time now. I don't think there's any more questions in the chat, though I could probably keep going. So I'll stop there. Anyway, so thank you so much, Simon. That was really good. I really enjoyed that. I took some photos of some of your slides. So and I run a CAT service. So that was really helpful.